So I'm on.
You're on. Hide that. And off you go.
So we might make a start.
We might make a start. People.
Morning. Now I'm not going to take my coat off. It's too cold in Melbourne. So. For those that are online, we're just waiting for everyone to be seated in the room. Okay, my name is, for those that don't know, Nolene Bennett, and I work both at the National Centre for Antimicrobial Stewardship and the Victorian Healthcare Associated Infection Surveillance System. Okay. Clyde et al. In 2015 published an article, Effectiveness of a Multifaceted Intervention for Potentially Inappropriate Prescribing in Older Patients in Primary Care, a cluster randomised control trial, OPI-SCRIPT study. The aim of this study was to investigate the effectiveness of a multifaceted intervention in reducing potentially inappropriate prescribing in Irish primary care. The same team in 2016 published an article, Sustained Effectiveness of a Multifaceted Intervention to Reduce Potentially Inappropriate Prescribing in Older Patients in Primary Care. The aim of this later article was to determine whether the immediate improvement in potentially inappropriate prescribing in the short term was sustained at 1 year follow-up. Now, there are three reasons I chose this article. One is I think any intervention that has a sustained effectiveness in reducing potentially inappropriate prescribing is important for us to know about. The other is that it was published in a journal called Implementation Science, and that, of course, looks at how evidence becomes practice in the real-world settings. And most certainly in infection control, that's gaining some traction at the moment. The third reason was that somebody passed the article to me and said you should do it for Journal Club. Just to define for this study potentially inappropriate prescribing is the suboptimal use of medicines that introduce a greater risk of adverse drug effects when a safer, as effective alternative is available to treat the same condition. So the eligibility to participate in this study, general practice, there had to be at least 80 patients aged 70 years or older, and the practices had to be based in Greater Dublin. The patients had to be aged greater than 70 years and have at least one of the pre-existing PIP indicators. A panel was brought together to review the literature and assess the PIP indicators suitable for study inclusion. The inclusion criteria were the prevalence of a PIP indicator, the clinical significance, and the evidence base to support inclusion. The panel reviewed lists or guidelines that are available for healthcare professionals to use to improve the safety of prescribing medications for older adults. For the most, these lists emphasise de-prescribing medications that are unnecessary. The B's criteria is one of the most frequently cited lists. It was first developed in 1991 and updated in 1997, 2003, 2012 and most recently 2015. It has one reference only to an antimicrobial. For the study, 34 PIP indicators were selected. These are some of the examples. I just want to highlight at this point that the proton pump inhibitor, the concern there was, for example, that it be discontinued earlier or dose reduced for maintenance, prophylactic treatment of peptic ulcer disease. So enrolment. There were 21 GP practices were enrolled, that's 88 minus 67, and 196 patients, that's 1,306 minus 1,110. Selection bias was minimised by collecting baseline data before minimisation, which was carried out by an independent third party. Practice minimisation is an allocation method commonly used in cluster randomised controlled trials to ensure balanced allocation of important cluster level attributes, such as practice size when cluster numbers are small. It was not possible to blind GPs or patients to allocations. However, the outcome assessed was later blinded. So in the intervention group, there was 11 GP clinics or clusters and 99 patients. In the control group, there was 10 clusters or GP clinics and 97 patients. For the intervention group, there were 3 interventions: academic training, medicine review, and a tailored patient information leaflets. For the control group, it was just usual care, monthly or 3-monthly prescriptions, and the patients a receipt of a simple patient-level postal feedback. So the academic detailing, it was one session where the pharmacist visited the practice to discuss PIP indicators, a review of medicines, and web-based pharmaceutical treatment algorithms. The medicine review here, they looked at potentially inappropriate prescriptions, alternatives, and background information. The detailed leaflets describe the PIP and the reasons why it may be inappropriate and outline the alternative pharmacological and non-pharmacological treatment options. The intervention was completed at 4 to 6 months. All practices received a report summarising participating patients and their PIP profile for use for internal audit purposes. GPs and patients then returned to their usual practice. The follow-up at 1 year in the intervention group, 4 patients only were lost to follow-up. In the control group, 6 patients only were lost to follow-up. So some results. If we look here, the proton pump inhibitor at maximum therapeutic dose was the most common PIP indicator for both the intervention and the control groups. There were 2 primary outcomes. Firstly, if we look at the proportion of patients with PIP, at the intervention completion, the intervention group participants had significantly lower odds of having PIP than the control participants. And similarly, at the 1 year follow-up, the intervention group participants had significantly lower odds of having PIP than the control participants. The odd ratio was adjusted for age, sex, baseline number of PIP drugs, baseline number of repeat medications, number of general practitioners, and the practice location. The mean number of PIP drugs was the second primary outcome. At the intervention completion, the mean number of PIP drugs in the intervention group was significantly lower compared to the control group. And similarly, at the 1 year follow-up, the mean number of PIP drugs in the intervention group was significantly lower compared to the control group. If we look at a secondary outcome about the proton pump inhibitor, intervention participants had significantly lower odds of having a potential inappropriate proton pump inhibitor compared to the controls. No significant differences were found for any of the other secondary outcomes. So the strengths of this study, it was a rigorous design of a clinically relevant intervention. There was high retention rates, completeness of the prescription data, and it was conducted in a primary setting using existing resources. Limitation, external validity, only 32% of the invited GPs enrolled in the study. So in conclusion, short-term interventions can have a long-lasting effect on improving PIP, thereby potentially reducing adverse drug events. Now, as I read this article, some of my random thoughts, if you like. One is I just think acknowledge that for GPs, they really have to have such an extensive knowledge base about medications. I wonder if the BEES list or a similar list is being used in Australia. I'm aware that the MPS medicine-wise do academic detailing, and currently they're looking at visiting GPs to talk about managing depression and type 2 diabetes. I wonder if we can similarly test the effectiveness of our interventions as this study, and is the effect of our intervention sustained over time? Does anyone want to add to those thoughts? Yeah, Tom.
Well, how much are we aware about, through this de-prescribing, have we had any adverse effects in terms of, are people on medications that in fact should have been on, and their mortality is worse or their morbidity is worse once we get prescribed the medications?
No, well, this study didn't follow that up, no.
And
But that's a good question.
Is there more, less adverse effects on CD4 or other admissions to hospital in the de-prescribing group?
Sorry, can everyone hear the question? Do you want me to
repeat the question so everyone online can hear what the question is?
Just for those that, the question from Tom was if for those patients or clients that were no longer prescribed the medication, was there any adverse effects having been de-prescribed? And my answer to that is no, as far as the study goes, they didn't look at that. But that would be most certainly to look at in time.
Yeah, they've looked at that in Israel,
Okay.
a much more aggressive de-prescribing study where they took a lot of people off lots of medicines and there was no. A lot of these people don't need to be on.
Yeah, no, I mean that's our gut feeling that they don't need to be on lots of these medications and so forth, but it would be interesting to see, to hear that in fact is the case.
Can I ask the audience a question then? Has anyone you'd look to use or seen references about the bees list or other lists in Australia?
There's another PhD student up the road who's looking at use list and with the European.
Yes, that's right.
Yeah, and apparently the European list is a better predictor of adverse effects in older populations.
Sure.
We did just like a journal published paper discussing that not long ago.
Sure. Well, certainly the Europeans like their list better. The bees is an American list.
Yeah.
My take on it, I think, is I actually think that quality use of medicine should be standard of care. And I don't think we need to be doing cluster randomised studies to say that we need quality use of medicines in aged care. I just think get on and do it. I mean, really, it's part of an expectation that accreditation standing forward. And we know the issues are going to be the same. And even worse, if there's just no regular sort of review process, then it's just not structured the patient's charts to review every week.
Sure. I'll just check if online there's any questions. That's a no. Any more questions in the audience? Any other comments, thoughts? Fantastic.
Could you see through my glasses?
No. I've got my glasses, so thank you.
Hey.
People can see you. I'm feeling paranoid now, Phil. I'm going to take a slightly different tack this morning. My name's Anne Bull, if anyone doesn't know me, and I work at the VICNISS Coordinating Centre. Just work out which buttons to click. And I'm going to talk about some work that we've done over the past 13 years or so on surgical antibiotic prophylaxis. I'll mention a couple of papers that we have published over the way. So, just to start off, click the mouse, do I feel? When I work this out, how to click the mouse. You'll have to show me, Phil. I need remedial lessons. Which button is it?
Just any
the right one. Anyway.
Well, there's just the one button on that.
That one?
No, just there.
Oh, just click the general mouse. Okay, when I get this out. Sorry. So just to give an overview, if anyone hasn't heard of VICNISS, We're the Healthcare Associated Infection Surveillance Coordinating Centre for Victoria, and our surveillance system is based on the United States National Healthcare Safety Network System, which was formerly known as NIST, for those of you as old as I am. So since 2003, along with the surgical infection surveillance data, we've also collated data on surgical antibiotic prophylaxis. And so we have continuous antibiotic prophylaxis data for cardiac bypass procedures for 5 out of the 6 public hospitals in Victoria that are doing those bypasses. We have data on almost all of the hip and knee replacements performed in public hospitals in Victoria, along with data on a lot of other procedures, and we have some data from private hospitals since 2009, so for about the last 6 years. And just to give a summary of the data that we have now, we have data on over 30,000 cardiac bypass surgeries, on over 90,000 joint replacements, more than 13,000 colorectal surgeries, over 80,000 caesarean sections, and more than 9,000 hysterectomies. So all of those records, we have data on antibiotic selection or antibiotic choice, the timing of the first dose, and the duration of the prophylaxis, so whether that was discontinued within 24 hours or not. I'm going to talk today mainly about the cardiac surgeries, the colorectals, and the joint replacements. We've just had a medical student who's done an extensive analysis of the caesarean sections, and she'll probably be publishing a paper on that data, a paper or two. The most recent records, we've been collecting dose information more consistently, and we've also got data on second dose for long procedures, so procedures greater than 3 hours, and I'll just talk a little bit about that at the end. So we have a lot of information on those procedures. So in about 2005, we published this data on compliance with surgical antibiotic prophylaxis. So this paper is about 10 years old now. So I'm going to talk about some data in that paper and give an update on some of the differences that we've seen in the data since. So one of the things, and you'll see Phil Russo's name on that paper, because those are in those days he worked with us. And so that data went up to nearly the end of 2004. And one of the things that we saw in the early data was that, in particular, timing of administration was very poorly documented. And you've probably all seen those anaesthetic charts where the anaesthetists tend to just put a little mark around about when they give the antibiotic. So the percentages of where the timing of first dose was recorded was quite poor. So for cardiac surgery, you'll see there around about 33 to 40% was documented at all, or that where the infection control consultants who are generally collecting this data were able to determine where the timing was recorded. And I've looked at the data since then, and just to compare, so it's now around about up in the 90s, so where the timing is now able to be documented. And that's generally due to feedback to the hospitals and pressure on those anaesthetists to be better at recording that data. Some hospitals went as far as redesigning their anaesthetic sheets so that it was easier for the timing to be recorded. So that was generally feedback given to the hospitals over the years. And some of the smaller hospitals in particular, Nolene and I went out and gave talks in the early days and gave a lot of feedback to those hospitals. In terms of improvements in compliance, this table showed antibiotic selection and timing. So if you just look at that end column there, which was the percentage of the procedures where selection was concordant or adequate, and in terms of being concordant or adequate, we look at whether antibiotic choice was directly concordant with the guidelines or whether it was considered to be adequate for the procedure. And by that we mean it was likely to cover the range of pathogens for that procedure. So in terms of cardiac, it doesn't seem to have changed much, but if you just look at orthopaedic, 83% in the published paper and now gone up to 89%. Colorectal surgery started from a lower base, about 56%, now up to 72%. And so it may not look that impressive in terms of change, but in terms of orthopaedic surgery, that is up 6%, and that actually represents about 4,700 patients per year that are now compliant with the guidelines that weren't in 2004. And for colorectal surgery, that represents about 2,000 patients a year. So in total, that's nearly 7,000 patients that are now receiving prophylaxis that is compliant, that wasn't about 10 years ago. And we're not claiming that that's all due to what we've done, but it's certainly different to what things were in the early days. So in terms of just having a look at the drug regimens, for cardiac surgery, in 2003 and 2004, when we published that paper, there were 47 distinct drug regimens that were used during that time period, which astounded me when I first noticed. Some were only given to one patient, of course. Now, in that pie chart, the ones that are in green are the ones that were concordant with the guidelines at the time, and then I've used various shades of colour as they got sort of differed from the guidelines somewhat. The red are where there was no prophylaxis recorded. So in that time period, there were 42% that were compliant with the guidelines at the time. Just in the fine print, it's over the entire time period we've been recording, there are 186 different regimens used, which I find is interesting in itself. And then just to compare, I've looked at the most recent 2 years of data. So in that time period, 36 distinct regimens have been used. There are now 62% of procedures where the prophylaxis is directly compliant with the guidelines as they are now. So that's an increase of 20%. And that represents about 600 patients per year now getting what we consider as the optimal or the compliant choice. And the same thing for orthopaedic surgery, so that's hip and knee replacements. So 2002, 2004, there were 58 distinct drug regimens used in that time period. Interestingly, in the last 2 years, there were 74 distinct ones used. And as I say, a lot of them only given to one patient, so I can't explain that. I'm not a pharmacist or an ID physician. I need to consult my colleagues about some of the weird and wonderful things that were given to individual patients. But the interesting thing is that there's been an increase, and that's good to see, that in 2003-4, 65% of procedures were compliant, and now there are 89% compliant. So that's an increase of 24%, and that represents around 2,500 per year additional people getting prophylaxis that's completely compliant with the guidelines, in terms of choice anyway. For colorectal surgery, once again, we were starting from a much lower base for some reason. I've always thought if you were getting colorectal surgery, you'd pretty much want to be getting your prophylaxis to be compliant, but for some reason it always seemed to be worse. Whether or not that represents more emergency procedures, we need to look into that a bit further, but only 36% were completely compliant for choice in the early years. It's gone up to 62, which is still not ideal, you wouldn't think, but there may be reasons for that which I don't understand, but it has gone up by 26%. Overall, there's 162 different regimens used over the entire time period of 13 years worth of data there. In terms of changes in compliance with timing of administration of first dose between 2003, 2004 and the most recent 2 years, for cardiac surgery it's actually gone down by 10% when you look at that time period. Changes in timing for cardiac surgery, and I find, often reflects a change in the use of vancomycin. So whether that represents an increase in use of vancomycin, I'd have to look further at, because vancomycin is the one where the timing is often difficult to comply with, as you know. So we'd have to look more closely into whether that represents an increase in vancomycin, although that's something that we haven't really seen. It's more a decrease, so we'd have to look closer into the reasons why that's occurring. Orthopaedic surgery, the compliance has gone up by 5%, and colorectal, pleasing to see that it's gone up by 17%. Another publication that we put out in January 2006, we looked at the impact of vancomycin surgical prophylaxis, that's vancomycin as a sole agent, on the development of methicillin-sensitive Staph aureus surgical infections, because there was some evidence that vancomycin is less effective than beta-lactams against MSSA infections. There was a previous publication in 2002 that had shown some evidence for that, and our publication backed up that finding. We found that prophylaxis with vancomycin as a sole agent was significantly associated with both any surgical site infection and with MSSA, SSI, after adjustment for age, procedure duration, surgical antibiotic prophylaxis timing and ASA score. And notably, the Australian and the United States antibiotic prophylaxis guidelines now recommend the use of a beta-lactam in addition to vancomycin if you're going to use vancomycin for prophylaxis. And the therapeutic guidelines brought that in version 15, 2014. And so I just had a look at the data that we report, and the use of vancomycin as a sole agent for cardiac and orthopaedic procedures, which are the ones that vancomycin's used for generally. And so I had a look at our procedures between 2003 and 2006, and there were 25,000 procedures where it was used as between those times, cardiac and ortho, and there were 5.3% of those procedures where vancomycin was used as a sole agent, whereas between 2007 and 2015 there were only 1.9% where it was used as a sole agent. So just from that quick look, it looked a bit as if the use of it as a sole agent was decreasing. So some more recent work that I've just been looking at, because we haven't had the second dosing information for all that long. So I just looked at the last 3 years where we'd had second dosing for long procedures, and I looked at this by procedure group. So first of all, the cardiac procedures and the percentage of procedures which were more than 3 hours where a second dose had been administered. And for cardiac procedures, there was pretty good compliance, about 70% of cardiac procedures longer than 3 hours, a second dose had been administered. This is of beta-lactam antibiotics, which have a shorter half-life, were the only ones that I considered. Orthopaedic procedures was a lot lower, about 25%. Colorectal procedures, about 43%, and other procedures, 20%. And those other procedures were generally, I think there was some things like spinal fusions, there was a few hysterectomies in there, and I think a few small bowel surgeries. So that was interesting to see the difference between the procedure types and the second dosing. So we need to look further into that. Like I said, we haven't been collecting that consistently for very long. And I don't think we're reporting that back to the hospitals as yet, are we, Judy? No, so we need to get a report back to that. So in terms of how we report this data back to the hospitals so they can act on it, for those who don't know, we have this secure user portal these days where the hospitals can directly log in and do their own reports. So they get a report that looks something like this for their compliance with the therapeutic guidelines. So for antibiotic selection, they'll get a report. They can do it by quarter or annually. And I usually tell them to look first at this column here, which tells them the percentage of procedures where the antibiotic choice was inadequate. So this one's obviously by quarter, and they can see what percentage of their procedures. This column, first column, gives them the number of procedures by quarter. This one gives them the percentage of those procedures where the choice was considered to be inadequate, and we have an algorithm that determines that choice, that figure for them. And we advise them to discuss that at their infection control committees and so on. This report looks at the compliance with the therapeutic guidelines at the timing of the first dose, and I've chosen this one to show you an example of where this is cardiac surgery by quarter, and this hospital, something's obviously happened here where they've determined their timing wasn't concordant for some reason. Around about the 85%, 70 to 80% of their procedures for some reason weren't concordant, and it's gone right down to about 8 or 9%. And we also provide them with a column telling them where the timing was unknown. So that didn't appear to be a documentation problem. So not quite sure what was going on there, but something's obviously changed quite a lot over that time period. We also report results of our surveillance to the Department of Health and Human Services. Got to get the name right because it does change. We report quarterly on hospital performance, and this occurs under the Victorian Health Services Performance Monitoring Framework. The requirements for each health services is outlined under their current Statement of Priorities document, which is an agreement between each health service board and the Department of Health. Now, we're not required to report on surgical antibiotic prophylaxis directly, but the Department of Health now asks us to report any hospital that's underperforming in any way, basically. So as a backup, if a hospital is underperforming, we are asked to report. So if a hospital is performing particularly badly, we are asked to report on this. And that's like a way of covering themselves. And that's only happened in the last year or so. The department's very interested in knowing about hospitals that are underperforming in any area of quality and safety. And I think that's due to an increased media focus in the last year or two. So some current work that I'm doing is looking at comparing the effectiveness of different antibiotic combinations and also examining the pathogens for any surgical site infections and looking at the antibiotics that were actually used for those procedures that did get an infection. And I think that might be it. Kaz.
Can you just describe to the group the different ways you do surgical surveillance in type 1 and type 2s and the different options that hospitals have? Who determines all of that?
Well, we determine that the larger hospitals, which we determine were hospitals with more than 100 acute beds. So from the very start of the surveillance, we basically divided the surveillance into two groups. So the hospitals with more than 100 beds that have ICUs and do a lot of surgery basically follow the NHSN model. So they do surveillance for surgical site infections. Smaller hospitals that don't do a lot of surgery, they can choose to do surveillance on the surgery they do is obviously much less, so they can choose to do an option where they do surgical antibiotic prophylaxis. They'll do 50 procedures on 50 procedures, sort of any procedures, and they will look at those procedures and do compliance with prophylaxis. Is that what you're meaning, Kaz? Yeah. But they do more process indicated surveillance rather than outcome indicated surveillance. They do look at some outcomes, but they have a different program, and that program's been developed mainly by Bennett in the early days, because when we looked at internationally, there wasn't really a suitable surveillance program for smaller hospitals. So no one internationally really had a surveillance program that was suitable for hospitals that didn't have ICUs and didn't do a lot of surgery. So that's where we looked into a program that was suitable, and it's a mix of process and outcome indicators and more looking at if an event does happen, like a Staph aureus bacteremia, what should they do about it, or an MRSA, or they, as I said, they do look at process indicators like surgical antibiotic prophylaxis if they do some surgery.
My second question is just to talk about the culture of surgeons now. And I remember in the early days there were some notable examples where particular hospitals refused to contribute. And how did you and the government deal with that?
Refused to contribute altogether?
No, there were some issues around some of the orthopaedic units, thinking that they were special, although, you remember.
I blanked it out. I think I may have blanked it out. Phil might want to comment on some.
There was a cardiothoracic group, So how did you deal
Yep.
with it then? How was that done?
Look, it was an issue that had to be dealt with in a number of different ways, and that was politically and through engagement with various groups, craft groups, and also the colleges. So it was important to get these people on time and on side, I guess, and there was no magic wand, there was no one solution, and I'm not going to be disparaging to any particular groups, but you've got to, in this situation, you've got to be able to work with all these groups and understand where they're coming from. And clearly there was concern about the fact that they may be unreasonably labelled as poor performers or dangerous operators or whatnot. So all those considerations need to be taken into account. But I don't know if much was achieved whilst I was at VICNISS, but I certainly think now that the situation is much different now.
It's very different now.
Then. Yeah.
Because I think once the SNAPS results come through nationally, because it covers a much wider range of surgeries, because it's up to the hospital to choose what they do, it's going to be very interesting to see the reactions from the surgical colleges with the breakdown of different craft groups, I think. Because clearly the orthopaedics have had a culture of being very, well, they've got the joint registry and the cardiothoracics as well, and then obviously the C-sections for a long time. And some of the other groups have never had any sorts of reporting of outcomes. So I'm just interested in your thoughts, the VICNISS team's thoughts on how we deal with that once that data starts coming through.
I think it all relates to the purpose of the activity, and the idea is not about punitive action against any particular single operator. It's about finding the gaps and improving the systems. And I think that's a real important issue. This is about quality improvement, patient safety. It's not about being able to put somebody's face on the front page of the newspaper and blaming them. Even though there's always that potential for it to happen, I think the emphasis needs to be on performance improvement and system improvement rather than individual basis.
Can I just say, I think it's hard work, and I think you have to go and meet and talk and meet with them, so that they see you as who you are and your intention. It's not just sending them a report and that's the done deal.
I think you might need to get them talking to their colleagues, like their colleagues that are used to this kind of thing, like those surgeons that aren't used to it might need to be brought together with the cardiac and the orthopaedic surgeons who are in a way their peers, who are used to this kind of scrutiny, that they might be the ones that need to be in some way educating their colleagues that may not be used to being under this sort of scrutiny and saying, listen, this is the way of the future. This is not going to go away. You are going to be, your practices are going to be under scrutiny. It's not about punishment, but this is about, you know, you're going to be looked at. This is what's going to happen. What I think will be interesting perhaps is when you start saying to people, you're giving prophylaxis for removing moles or doing these sorts of things. That's what I think is going to be interesting, and perhaps you shouldn't be. I think that side of things could also be interesting.
Yep.
I'll just introduce Zeb, by the way, in case you're wondering why this strange person sitting there. So Zeb's actually a medical registrar at Epub in Melbourne. You're doing a specific actually, ethics PhD, and he's very interested in antimicrobial resistance and stewardship, and he's actually putting together, he's going to write a book, and he's got invited authors. So I'm introducing Leslie to Zeb today because of the work with the palliative care and the end of life managing antibiotics and aged care. So he's a very interesting person.
I'm editing the book, I'm not writing.
Some other, maybe there's ethics in animals as well. So we can anyway. So I thought I'd invite him along, particularly because he was in aged care journal, something to meet some of you today.
So I was keen to know about overuse data, because a lot of the time on the ward we see surgeons that continue antibiotics after surgery for no reason, and that's got other implications, whereas the language of adequacy implies that we're trying to ensure that infections will be prevented, which is obviously one important thing, but what about overuse?
Yes, well, I didn't present any of the data on overuse, mainly because that was one of the easiest things to bring into line, and mostly it hasn't been a problem. It's been a problem in a few hospitals where it does continue to be a problem. It's generally an individual surgeon problem, where Nolene and I went to one famous meeting at one famous hospital. It'll be like a regional hospital, and they'll ring up and they'll ask us to go there. And Nolene and I went to this one famous meeting, and they'll invite the entire hospital there. The CEO will be there, everyone will be there, and we'll all be in this room, and we'll all be there because of this one surgeon. And we'll give our talk, and the one surgeon will sit there with his arms crossed and his body language, and he'll be the one that'll be giving the prophylaxis for 2 weeks after the hernia repair. And we all know that we're all in this room because of this one surgeon, and he'll just sit there staring, and he'll ask some questions about something later, and you'll know afterwards that you'll just have to wait till he retires for anything to change. But generally that's been the easiest thing to bring into line, and generally the data I think are quite good on that for us.
If we're looking at the SNAP, if we're looking at the point prevalence surveys,
Yep.
those indications where it's surgical prophylaxis, there's 1/3 is still extended.
For surgery, for
surgical
yeah.
prophylaxis as the indication, that's one of the key findings of the point.
I would have thought in Victoria that ours was quite good, Kaz. I could be wrong if I went and looked at it, but
I don't think it's that different anywhere, is it, Kaz? Amongst states.
No, it was fairly similar.
It was fair. Look, it might actually, you're right, it might be a few percentage better, but I think it's normal. And we're talking more than 24 hours, so it's always hard when
I think yes, that's the thing that is hard. If it's recommended for 3 8-hourly doses and it goes for 28 hours, and you get those people who are the Judy Bretts of this world, because she's, Judy's always like right on, and if it's 28 hours and they'll tick, yes, it was longer than 24, whereas I would tend to say if you're giving those 3, and I'm the epidemiologist supposed to be, if you're giving those 3 8-hourly doses and it's 28 hours, I would tick no, it's I would tend to go that's compliant. And so it's very difficult to, is that compliant or not if it's 28 hours? So
I sort of think maybe we need to talk about the surgeons is in the number of doses.
yes,
3 doses stop, as opposed to you can't go more.
yes.
So in their head it's easy for them just to count 1, 2, 3.
Yes. So we may need to look. Yeah.
We've got it down there, Julie.
Have we? What? Have we?
Doses and it goes slightly over.
Yeah.
It's
24 hours.
Yeah.
the language as well.
There you go.
I mean,
See, Judy's onto it before I've even. That's typical. She's onto it before I've even.
So, because we are talking about surgical
Yep.
prophylaxis, like the national, looking at
Yep.
what language do we use?
So I probably should have presented that data, and when I write the paper, because Mark's on my back too, I will definitely look at that data. I can get it out for you and see what ours is like.
But
in Victoria.
These are just in these targeted groups, right?
Yep.
So we know that the plastics, for example,
Yes.
are
Yes.
pretty diabolical.
Yes, that's right.
Paradoxically, the cholera is very good.
Yes.
Even the eggs are very good, aren't they? So they.
Yeah. So I think we might be talking different things. So I'm talking cardiac, orthopaedic, colorectal, so where our compliance is probably very good, whereas you're probably talking the plastics and that where
I
it's.
think it is different. And I think that comes from this culture of not having
Yes.
sort of feedback loop about quality prescribing.
Yeah, so when I'm thinking ours is pretty good, I'm probably talking the different
Well,
surgeries.
down the track of having
Yes.
been wanted, I suppose.
Yes, that's right.
But, the Commission have come back to us now, and they have got buy-in from the college, and so I think there's going to be a meeting coming up with Leon and Trish.
Yep.
And the Commission has just a sort of planning the next step with the colleges, because I think if we can get this window, so I think it's really important that VICNISS are in that space.
Yeah. Sure.
Got some questions.
Oh,
How do I?
Just asking to speak up in the discussion.
Oh, sorry.
there's a repeat question.
As in her two seconds.
Repeat the
Well, I'm going
questions.
to write a book about the famous VICNISS meetings.
Too late, I didn't read it. I'm not used to it, I didn't read. Please repeat the questions.
Thank you.
Oh, thank you everyone for listening in and goodbye.
So we've got some new faces in the room. Leslie, have you met everyone?
I've met some, but not all.
So Leslie, of course, is joining us in the general practice stream.
Well done.
And
Do you want to just close that and I'll quickly stick out?
Oh, I
Worked out here.
Not yet, no.
Oh, you have?
yes.
So,
Too many people
Trash.
listening on.
yeah, so then we actually